And just give a minute for participants to join in.
Sure.
All right, a very warm welcome for another session of Academic Radiology Education Program. I'm Dr. Janardana Panatapura. I'm one of the cardiothoracic radiology from Wake Forest Baptist School of Medicine in North Carolina. So just a very brief introduction of what we are. AREP is a nonprofit initiative aimed at providing high-quality radiology education to colleagues worldwide. So this is established in October 2021 and based at the Department of Radiology at Wake Forest University School of Medicine. And it offers free online education resource and live webinars featuring academic radiologists from the leading US institutions. This program is designed to bridge education gaps, particularly from radiologists in resource-limited setting, by sharing expertise and fostering global collaboration. So we host bi-monthly webinars from January to October covering various radiology subspecialties. These sessions are well attended with up to 700 participants per live event and include contribution from esteemed institutions. AREP reaches extends to radiologists in different countries in Asia, Africa, and Middle East. This program is driven by the dedication of its committees, moderators, and speakers who work tirelessly without external funding. In addition to webinars, we offer projects like Radiology Excellency Program, which focuses on mentoring and specialized radiology challenges in various countries. So today, we have a great session on the congenital GU anomalies in pediatric radiology. And today's moderator would be Dr. Akshay Baheti, who's a great friend of mine. He's a professor in Department of Radiodiagnosis in Tata Memorial Hospital and Homi Bhabha National Institute in India. He's also an affiliate instructor of body imaging at University of Washington Medical Center in Seattle. He's published over 80 peer-reviewed journals, and he's also a co-author of Known Unknowns of Everyday Radiology Practice, a practical radiology handbook. And also, he's an associate editor of Sutton Textbook of Radiology, 8th edition, and he's a member of International LIRADS Working Group and a member of RSN Education Exhibit Committee. So it's my pleasure to introduce Dr. Baheti, and over to you, Dr. Baheti.
Thank you so much, JP. Thanks for this kind introduction. And just to clarify, I also did a fellowship in pediatric radiology at Seattle Children's Hospital, because someone will wonder why am I moderating this session.
Oh,
So
nice.
also practice pediatric oncoradiology at my institute, which is a cancer institute, along with, of course, abdominal radiology. And I am so glad to be here. Thank you for this opportunity. And it's my pleasure to introduce today's speaker, Dr. Matthew Thompson, who's going to speak on congenital GU anomalies in pediatric radiology. Matt has completed his residency and fellowship in pediatrics from Duke University and is currently assistant professor in pediatric radiology at Bennett Children's Hospital and at the Atrium Wake Forest Baptist Health, along with also being the section chief from 2022 onwards. He has numerous publications to his credit, and I think this is a case-based session, so everyone is definitely going to enjoy and take home a lot of important teaching points from this. Looking forward to this, Matt.
Okay, thank you very much. And it's I'm very glad to be here with all of you. And I think this is a really great resource in sharing radiology knowledge throughout the whole world. So with that, we'll get started here. So I just have a note about all the images. All the images are from Wake Forest University School of Medicine. There's a few that I took from some textbooks just to maybe illustrate a point, and I'll show that as we go through. Now, here are all the cases to be covered. It's quite a lot of cases. It's not exactly exhaustive of all possible congenital GU anomalies, but it does encompass what I think are some of the more common GU anomalies or the types of GU anomalies that require some problem solving with imaging. So here's our first case. This is a 1-month-old female with prior fetal ultrasound finding of a cystic kidney. Let's take a look at this ultrasound image. So this was taken after birth. That box surrounding the kidney indicates that it's a Doppler image. So it's looking for blood flow. It's the right kidney, and you could see that there's some cystic spaces there. In addition to no demonstrable blood flow in the cystic spaces, there was no discernible renal parenchyma seen on additional images. So the findings here, they're pretty non-specific. Taken by itself, this would be a fairly large differential of multicystic dysplastic kidney, UPJ obstruction, just, your run-of-the-mill hydronephrosis from various causes, cystic dysplasia, maybe even a cystic malignancy, or a very rare congenital megacalyces. So, with all patients that end up getting radiology studies, they almost all get labs, and the labs in this patient were normal. So the very first thought I would have in seeing such a study like this would be MCDK, multicystic dysplastic kidney. But I'm not very sure about that. So how I tend to report it is a cystic dysplastic kidney, recommending a nuclear medicine renal function scan for further evaluation, because I have a Doppler image, and Doppler is sensitive for blood flow and therefore sensitive for function, but not as sensitive as the nuclear medicine scan. So I don't diagnose MCDK with an ultrasound without getting that renal function scan first. So here's the renal function scan here. I always have to remind the residents that when you look at an image here, it's the patient with their back towards you. So now that's the left kidney and that's the right kidney, kind of the opposite of what you think with a coronal CT, for instance. And this is a technetium 99 labeled MAG3 renal function scan. And note, there's no activity at the location of where you expect the right kidney to be. No excretion was noted. So this turned out to be a case of a multicystic dysplastic kidney. Now I feel very confident in that diagnosis. Usually that diagnosis is suggested in utero, but as I mentioned, we can't be absolutely sure. We need to confirm on the postnatal ultrasound, the nuclear medicine renal function scan. Most of these cases are sporadic and non-familial, meaning non-genetic. Most are going to involute, and that will be confirmed on the follow-up ultrasound. So that was case 1. Case 2 is a 17-month-old female in an MVC, and in trauma cases, they always get these trauma CTs. So you have this CT here. This is just an axial slice. We see that the kidneys are fused across the midline, just below kind of a little bit low, below the level of the IMA takeoff. You can see a little bit of the liver coming in there. So we're kind of low. And this turned out to be horseshoe kidney, which is actually fairly common. 90% of these horseshoe kidneys are fused at the lower poles, and 10% would be a combination of upper and sort of the mid-pole region. They have normal insertion of the ureters into the bladder, and usually the kidneys function normally as well. But there are problems with having a horseshoe kidney. They're at high risk for, in the setting of trauma, this type of kidney can be easily injured. They're at higher risk for malignancy, especially TCC, and that stands for transitional cell carcinoma of the renal pelvis. Other malignancies like Wilms and renal carcinoid, they're susceptible to getting renal calculi, higher rates of infection, or renovascular hypertension as well. Sometimes the diagnosis is a little bit confused, not on CT. I think it's fairly obvious here. It's crossing the midline. It's very classic appearance of your horseshoe kidney. But if you have like an ultrasound, sometimes that can be confused with cross-fused renal ectopia, pelvic kidney, or maybe even just malrotated kidney, which we see a lot of as well. Here's another case of a 2-year-old, and it's another trauma scan for an MVC. Here's a coronal CT. This is post-contrast portal venous phase. And you do see what looks like fused kidneys, and it does kind of look like it's across the midline somewhat, but there's, a nice reniform image of the right kidney and the left, which seems like it's fully formed as well, just partly fused. So it's not exactly the horseshoe configuration. This is a good example of cross-fused renal ectopia. The upper pole of the left kidney is usually fused to the lower pole of the right kidney. The ureters, just as in horseshoe kidney, have a normal orthotopic insertion into the bladder. Just like horseshoe kidney, however, they're at high risk for complications like higher rates of hydronephrosis, nephrolithiasis, infection, and of course trauma as well. Here is a case of a 1-month-old with a UTI. Patient went on to get a VCUG, and this is very common. Kids getting a UTI is very a little bit strange at our institution. So they usually are referred to urology, and what urology first does is order a VCUG, which is what we do. We do a lot of these, almost 2 to 3 per day, or sometimes 50 per week. So it's primarily ordered to assess for reflux. And we see here that here's the contrast in the bladder, reflux into 2 ureters and into 2 collecting systems there. So this is a case of ureteropelvic duplication, 2 collecting systems and two ureters. And what is that? That's due to incomplete fusion of the upper and lower pole moieties during development. Now you can have either complete ureteral duplication, which we have here. There's 2 separate ureters inserting separately into the bladder in different locations, or incomplete ureteral duplication, where it starts out as a bifid ureter, but then they join together and it inserts normally into the bladder. That's seen about 70% of the time. You have a single ureter inserting into the bladder, and about 30% of the time you have 2 separate ureters. So there's complications with this congenital anomaly as well. They can get reflux, as they have here. They have higher rates of hydronephrosis. They can get a ureterocele, which I don't demonstrate here, but that's kind of an outpouching of the distal ureter into the bladder, ectopic insertion of the ureter to the lower pole moiety, and that's that has a very classic appearance called the drooping lily sign, which you see here. There's reflux into the lower collecting system, and there's probably an upper collecting system that's obstructed that we can't see. So there's no reflux into that lower or that upper system. So sometimes that ectopic ureter can insert into the posterior urethra or into the genital tract, either the vagina or the penis. There's going to be no treatment, however, if the patient is asymptomatic of a duplicated collecting system, that is. But however, if they do have symptoms, there are some treatments such as ureteral reimplantation, which our urologists do a lot of, maybe even a heminephrectomy, which I see on occasion, or maybe even pyeloplasty, which is typically seen in another condition that I'm going to show you in a few minutes. Here's a 5-year-old boy with a recent UTI. You can see kind of a theme here with congenital GU anomalies. You're working up UTI quite a lot. So this is an image I took from Caffey's pediatric radiology. Notice the renal ultrasound here and the dilated calyces. The patient had several follow-up ultrasounds, and these calyces all had a similar dilated appearance. So differential with from the ultrasound findings would be congenital megacalyces, or maybe even hydronephrosis, possibly obstructive. We get these cine images of the ultrasound, which can show in real time. We can do these sweeps through the body of the kidney, and we can see if these cystic spaces are interconnected or they're not. And if it all is kind of connected into the collecting system, that's a good example of hydronephrosis. But if not, it's going to be other conditions, one of which could be congenital megacalyces. So how do you work this up? Typically, we can work it up with an excretory urography or an MRU, far more expensive examination. Here we're going to work this up with excretory urography here. This is another image that I took from Caffey's here. So in an excretory urography, they gave a contrast, and then they followed the image. They followed the excretion of the contrast from the kidneys, and you can see it's kind of collecting there in the right kidney into those dilated spaces. So there's contrast retention in those calyces, but there were no findings here to suggest obstruction. There was actually even a normal caliber renal pelvis. So this was a case of congenital megacalyces. It could be unilateral, as it is in this case, or bilateral. It's due to underdevelopment or hypoplasia of the renal medullary pyramids. This typically happens more often in boys than in girls. And you can imagine this can predispose to urinary stasis, and they can get frequent UTIs or even kidney stones. And there is technically no treatment if there's no obstruction here. If there is obstruction, there's the usual pyeloplasty, for instance, or even, if it's very serious, it could be nephrectomy. Let me show you about another case. This is a 13-year-old girl, another MVC with an incidental finding. Here's the CT, just an axial image here, post-contrast image. So the trauma CT was negative. The patient had no trauma, but the incidental finding was seen in the right kidney, sort of a cystic mass with this layering density there. There was a concern on the part of the ED physician for cystic neoplasm, so the patient actually got an MRI. And this is a haste sequence here, so it's fluid sensitive, and it shows that lesion to be T2 hyperintense, and it was very difficult to see the layering calcium, but on some other images, there was some low signal layering calcium that fit what we saw on the CT. And this was the post-contrast, so there's no enhancement. And the patient ended up getting multiple follow-up ultrasounds too, and there was really no change in the size of this typical lesion. So this is an example of a collegial diverticulum. It's a focal outpouching of the collecting system, mostly containing urine. That layering density, there's a lot of these labels in radiology. They call it milk of calcium. It's kind of strange. I don't know why they'd be thinking about milk, but I think it's because of the calcific density. If it hasn't calcified, it can layer in different areas, that dense fluid, depending on how the patient is lying down on their side or on their back. Now, this particular entity also predisposes the patient to infection, calculus formation. You can imagine if this forms a stone and blocks the collecting system, that would be, they would have quite a lot of pain. Let's look at another case of a 2-day-old male with hydronephrosis seen on a prenatal ultrasound. Here's the hydronephrosis. That's a very dilated renal pelvis there. There's the Doppler image. I always tell the residents, sometimes you're looking at this. Now, this is probably pretty obvious that that's hydronephrosis, but sometimes you're not quite clear. And if you're not sure, is that hydronephrosis or are those just renal vessels? Look at the Doppler to make sure that you can correlate with this image. And see, this isn't filling in with color, so it's not vascular. So it's true hydronephrosis. So the Doppler, though, is also helpful for looking for a crossing vessel. We have obstruction here. So we either have a shadowing calculus seen in the ureter or dilated ureter to the level of the bladder. There's a lot we can evaluate with ultrasound here. Maybe a crossing vessel crossing the proximal ureter, causing this obstruction. This patient had multiple follow-up ultrasounds, and they had persistent hydronephrosis and only proximal hydroureter, not distal hydroureter. So, and the patient was being followed by urology. So they wanted to know, what's the renal function here? So they ordered renal scintigraphy, and this is with giving a little bit of Lasix, which causes, increased urine output. They wanted to assess for renal function with that study. And this is just a single image that I'm showing here. And so this is, again, you have to kind of flip in your mind which kidney is which. This is the left and that's the right. There was prompt excretion of contrast from the right collecting system at 4 minutes, which is really what you want to see. But there was retention of contrast. This is the 36-minute image in the left kidney with very slow excretion. However, the renal function was 50-50, 50%, 50%. So this is an example of ureteropelvic obstruction. Just a little bit of a joke here. It was, at least when I was in residency, they called it, the other name for nuclear medicine was unclear medicine, which was just kind of always a little bit funny. But this is like a perfect image which shows, wow, where's the anatomy? And a lot of nuclear medicine is like that. Very highly specific tests that give can really give a great diagnosis, but as far as the anatomic detail, very poor. So in ureteropelvic obstruction, this affects boys more than girls, and it's usually more common on the left than the right, as it is in this case. 30% of the time it's bilateral. Most of these are due to intrinsic narrowing at the UPJ, the ureteropelvic junction, and less common causes would be a polyp, fibroepithelial polyp, or crossing vessel. And remember, we look for crossing vessel on the ultrasound with the Doppler too. However, if the renal scintigraphy, this examination shows renal function of less than 10%, and I get this from the urologist, they tell me that they plan a nephrectomy because a kidney with such little function is only bound to cause more trouble for the patient later on, so they just remove it. It's not routine to get an MR urogram, but I wanted to show you an example here. You can see the delayed excretion here. This is the left. And notice that you can't even see the ureter after that. The excretion, it did have excretion, but it just, this image, this early time point image didn't capture that. Notice the normal appearance of the right kidney, normal caliber ureter. So treatment for this, for ureteropelvic obstruction, is going to be pyeloplasty. They can be, they can have, they're not going to get the surgery right away typically. Urology will wait a year or even 2 years, and during that time, the patient can get, or is at higher risk for getting UTIs and urolithiasis because of this urinary stasis. So next case is a 2-year-old female with a UTI. Again, that's part of the theme, I think. Here's the left kidney. We see some hydronephrosis. We see some debris in the collecting system there. And some additional images showed pretty massive hydroureter all the way down to the bladder. See this, we're just getting the bladder image here and lots of dilated ureter there. So this is a case of congenital megaureter. And there's many causes. It could be obstructed. It could be refluxing, non-obstructed, non-refluxing, obstructed and refluxing, just these general categories of megaureter. To really know which category it is, you need to go on to an MRI, as we have here. This is an MR urogram. And we noted the obstruction in the distal ureter there. Notice the ureter is very dilated. You get a very good example of the dilated ureter here compared to the normal side on the right, the dilated collecting system as well. So this was, a little bit more specific diagnosis of congenital megaureter as we thought on the ultrasound, but the obstructed subtype. That distal segment is aperistaltic. Normally the ureter is peristalsis, almost kind of like bowel, but this absolutely did not move on all the other subsequent images obtained on this MRU. But the renal scan did demonstrate normal function. So in this case, for this patient, conservative treatment was just fine, meaning pretty much do nothing and kind of watch the patient, watch the renal function with creatinine. However, if function is impaired, urology might resect that small little fragment and do a ureteral reimplantation. It all kind of really depends on what's going on with the patient, the symptoms the patient might have. But the patient is probably going to get these follow-up ultrasounds for quite some time. I've seen a lot of the patients get yearly ultrasounds to see how the kidney's doing and, assessing the caliber of the ureters compared to prior scans. So here's another case of a 1-month-old female with fetal ultrasound showing a renal cystic mass. So after birth, the patient got an ultrasound. I think it was within the first week of life here. It showed enlarged kidneys and near complete parenchymal replacement by tiny cystic structures, as you can see here. It's difficult to even see normal renal architecture here. So this is an example of autosomal recessive polycystic renal disease. It's associated with pretty severe renal dysfunction, also with congenital hepatic fibrosis in an inverse relationship to the kidney disease. So if the kidney disease is very, very bad, the hepatic fibrosis doesn't seem to be as bad. If the kidney disease is not so bad, the fibrosis appears to be worse. It's a very unusual inverse relationship. Eventually, this is a very severe disease. So these patients will eventually require renal replacement therapy, dialysis, or even a renal transplant. So here's what it looks like on CT if you haven't seen that. Okay, again, it's just that complete replacement of the renal parenchyma. They're very enlarged. And here's an MRI image too, very striking appearance. So let's move on to another case. This is a 9-year-old male with a follow-up ultrasound. This is the left kidney. There's definitely, it looks like something cystic there, multiple cysts located throughout the kidneys. It wasn't replacing the parenchyma. This doesn't look as severe as that other disease, ARPKD we were just looking at. The patient had normal function, normal creatinine, but the follow-up ultrasounds were showing that the cysts were slowly enlarging and they were starting to get new cysts over time as well. So this was an example of autosomal dominant polycystic kidney disease. This is a less severe disease than ARPKD, which I just showed. It's the most common inherited renal cystic disease, in fact. And it's due to these chromosomal mutations. There's a PKD1 and a PKD2, and PKD1 is more severe. And also, this is always important for board exams. I always try to stress these kind of associations that are likely to be tested for our residents. So these ADPKD is associated with intracranial aneurysms, also known as Berry aneurysms. About 10% will need chronic dialysis. So that is a lot better than ARPKD. Still a little bit worrisome, but not as severe. Here's what it looks like on CT. Here's another case of a 12-year-old male with a systemic congenital disease. So he's just getting follow-up MRIs here. This is just a cross-sectional post-contrast fat-saturated image, so you can't see the fat here, the subcutaneous fat. And notice all these T2 hypertense subcortical lesions bilaterally. And this patient's getting his yearly MRI, so he is kind of used to getting this. With this image alone, probably cysts, but there's several sequences that they get along with that T2 or along with that post-contrast image. And here is one of them. It's called the in-phase image. And it shows high signal subcortical lesions, at least there in the left kidney. And it can be paired with this other image called the out-of-phase image. And it demonstrates at those exact same places a drop in signal at those locations. So these are angiomyolipomas, AMLs, in the setting of tuberous sclerosis, which happen to be his congenital disease. They contain a small amount of microscopic fat. So when you have these out-of-phase images, which I'm showing here, it drops signal, and an in-phase image, it tends to have that signal. The IP in-phase and the out-of-phase images, they're paired MRI GRE sequences. They get them together. They have the same repetition time, but they have a different echo time. So that's what gives them this different quality and imaging characteristics. That loss of signal, as I mentioned before on this image here, the out-of-phase image, is due to that microscopic fat that the lesion has. And that, knowing the patient has tuberous sclerosis, it's diagnostic of an AML. AMLs by themselves, they're rarely found outside of tuberous sclerosis, but there are a few guidelines for at least watching these lesions over time. For instance, if they start to increase in size and they're greater than 4 centimeters, the patient is at risk, or the AML is at risk for rupture, and patient can hemorrhage into the retroperitoneal space. And I've seen a few of these in residency, and there could be, this is a very vascular lesion, so there can be quite a lot of blood loss into the retroperitoneum when these rupture. So because of that, if it measures greater than 4 centimeters, typically they get a referral to interventional radiology and they do an embolization of the lesion. There's just kind of like trivia, something called Wunderlich syndrome. is when it does rupture and it causes shock, hemorrhage, and the patient goes into shock from the blood loss. AMLs are, they're fairly common in tuberous sclerosis. They're found in 25 to 50% of patients. Now, tuberous sclerosis, just a few more words about this. It's a phakomatosis or a neurocutaneous disorder, kind of a fancy word for that. They have multiple, I'm not going to show all the other lesions that they get because we're kind of focused on the GU system here, but they get benign tumors of the embryonic ectoderm and other locations like in the brain, for instance. Clinically, they present with a classic triad. However, this is not seen in all patients, but the classic triad is at least helpful as a kind of a starting point for what these patients get. Seizures, they have intellectual disability, adenoma sebaceum. It's mostly due to spontaneous chromosomal mutations. Here's a 3-month-old male with blood in the urine. Pretty concerning finding. Went on to renal ultrasound. This is a Doppler image showing, nice fill-in of vessels there in that lower pole of the right kidney and no real blood flow there, and hypoechoic appearance, kind of concerning appearance. So this showed kind of a renal mass here. Patient had a urinalysis. They were thinking rightly, is that an abscess? But it was negative for UTI. Patient went on to a CT, and this is coronal image post-contrast, and it shows that there is a little bit of enhancement, but it's a lot less than the renal parenchyma. So differential fairly wide at this point. Could this be Wilms tumor? It could be, but the patient's 3 months old. That's a bit young. Under 1 year old, you don't always tend to think Wilms, but over one, you would Wilms would be the number one here. Mesoblastic nephroma is another thought, and that fits the age, usually less than 1. It looks a lot like Wilms. It's another similar kind of tumor to Wilms. Abscess in the setting of pyelonephritis, we kind of evaluated that. Patient had a negative urinalysis and the white blood cell count was normal. And of course, it could be other renal tumors too. There's many others, clear cell sarcoma, rhabdoid tumor, for instance. So they went on to biopsy. And this was found to be a congenital mesoblastic nephroma. So this is the most common renal malignancy in children under 6 months. And it's usually suspected by palpating an abdominal mass, maybe by the mother, giving the child a bath or something like that, or, while nursing or something. You could see this mass isn't so big that you probably would feel it. But hematuria is another way of thinking, or at least working this problem up to see if it is a tumor, as in this case. So it looks a lot like Wilms, but that age, just like in so much pediatric radiology, as I try to teach the residents, age is really a key differentiating factor for going down a different differential pathway. You're probably not going to think Wilms here. You're going to think mesoblastic nephroma, given that 3-month-old age. Now, this is a benign tumor, pretty good prognosis after resection. So next case is a 2-year-old male with, again, UTI. Patient had a VCUG here. Patient had a renal ultrasound before this that was negative for any hydronephrosis or any concerning findings. Here's the VCUG, and we see reflux on the right. This is, there's a grading system, which I'm going to go over in a second, but this is a grade 2, and had reflux on the left. That's a grade 1. So this was an example of the vesico-ureteral reflux, VUR. And it's due to abnormal development at the ureterovesical junction. Let me show you a schematic here. This is how the ureter should normally insert into the bladder. Notice it's coming in at an acute angle here. So this is the detrusor muscle. When it contracts, it acts like a valve. It closes this off. However, in the setting of vesico-ureteral reflux, the ureter can sometimes insert perpendicularly. So you can imagine it comes in like this at this angle. The bladder contracts, it may not necessarily close it off like a valve. So let me tell you a little bit about the grading of reflux that we typically use here. This is an image taken from a small pediatric radiology text by Lane Donnelly, which is really a really great text for giving you all the fundamentals of pediatric radiology in one concise source. But anyway, in this schema, this shows that in grade 1, reflux into the ureter. Grade 2, it gets to the collecting system, but the calyces are very pointed. Grade 3, they're blunted. And I just tell the residents, grade 4, it's big, and grade 5, it's bigger. So these two can, sometimes this is almost a subjective interpretation between the two of them, but big and bigger helps the residents at least, and helps me. It helps me, a very simple way of understanding this. So most of the psychoureteral reflux is going to resolve, which is really wonderful. You know, when I diagnose this, typically in the fluoro suite, parents get very worried, and these percentages are really, you know, a great thing to take out of your pocket and give to the mother and say, hey, well, most of this is going to resolve. You know, that'll be followed by urology, so we'll see. Grades 1 and 2 resolve 83%. It's really great, and 73%, even up to 5, grade 5, which is really remarkable. There are some ways to predict resolution too. If the children present less than a year old or with prenatal hydronephrosis, they're more likely to resolve as well. Reflux is most commonly at our institution evaluated with VCUG, as we have here, but you can do radionuclide cystography as well. I'll show you an image there. Whoa, that's pretty unclear. So unclear medicine, again, is my little joke about that, but you know, the resolution is poor, but you can see that this is the radio tracer, and it is refluxing into the collecting system bilaterally there. And they use technetium, kind of the workhorse of nuclear medicine, mix it with saline, and they inject it into the bladder. This has been shown to have a similar sensitivity to VCUG, but as you can see, very reduced spatial resolution. You know, we have 5 grades for the VCUG. This has pretty much 3 grades. You know, you can't tell if the calyces are blunted, for instance. Here's another case of a 3-year-old male with a UTI. Clearly some reflux here on the VCUG, and an incidental finding on the right, very narrowed ureter, and this did not change with multiple images here. So this is an example of a congenital mid-ureteric stricture. Pretty uncertain etiology. There may be focal abnormalities in the wall of the ureter. Maybe it's due to focal ischemia during development. It can be associated with other congenital conditions that we've talked about here, multicystic dysplastic kidney, either on one side or both sides. It can be pretty difficult, as you can imagine, to differentiate from a UPJ obstruction, because we don't see this here, but what if the whole collecting system and the proximal ureter was dilated? You would be thinking, and the urologist would be thinking, hey, maybe it's UPJ obstruction, which actually is more common than a congenital mid-ureteric stricture. Treatment for this condition is going to be surgery, or, you know, if there are no symptoms, just conservative treatment, watching maybe a couple follow-up VCUGs to see if there's any change. This is a case of a 1-month-old male with bilateral hydronephrosis seen on a fetal ultrasound, so going to get worked up afterwards. This is the VCUG here. It's a lot of reflux there. But there's also dilatation of the posterior urethra, which you see a little bit of there. Let me show you another image. This is more the oblique image, which is what we get to assess the urethra. So this is an example of a bladder outlet obstruction, and there's a differential for that. Posterior urethral valves, much less common, but possible. Anterior urethral valves, anterior urethral diverticulum, megalourethra, which I don't think we see here, but anyway, it's on the differential. And this was a case of posterior urethral valves, really the most common of the items on that differential. Treatment is going to be transurethral valvulotomy, and we see a fair amount of these cases every year. So it's the same history, 1-month-old male with bilateral hydronephrosis seen on the fetal ultrasound, so we're going to have to work that up again. We got a VCUG here. This is a lateral view, very abnormal looking bladder, irregular urethra caliber as well. Patient had reflux too, which we can't, I don't have that on here on the image here, reflux to the kidneys. In fact, the whole appearance looked very similar to posterior urethral valves, which we just looked at. However, there were a couple other findings that led us down a different differential pathway on physical exam. The abdominal wall musculature had this very wrinkled prune-like appearance. Patient had cryptorchidism, which means the testicles were retractile and they were within the inguinal canals. So differential diagnosis with prune belly syndrome, posterior urethral valves, really only because of the imaging appearance, and another condition, megacystis microcolon hypoperistalsis syndrome, quite a mouthful. So this turned out to be prune belly syndrome, and those physical exam findings of the wrinkled appearance of the abdominal wall, and then the additional imaging findings of megacystis, the huge bladder, hydroureteronephrosis, renal dysplasia were other findings seen on renal ultrasound. So that all, taken together fits prune belly syndrome really well. There's another name out there, Eagle-Barrett syndrome. I think that's a little bit less well known, however. Possible causes of this are thought to be a primary mesodermal defect, maybe bladder outlet obstruction early in utero, very wide spectrum of disease to very severe to mild. And, so they're going to treat this with orchiopexy. They're going to bring the testicles back into the scrotum, reimplant the ureters, abdominoplasty if the abdominal wall musculature is pretty severe. And for the kidneys, dialysis and possible renal transplant if the renal dysplasia is very severe. So this is another case of a 1-month-old male with a UTI, with fluid coming out of the umbilicus, very unusual finding. So here is just an axial view of the ultrasound, and there's the bladder here, and there's this kind of cystic appearance there at the dome. So because of the, they tested the fluid coming out of the umbilicus, it was found to be urine. So this really fit patent urachus as the diagnosis very well. And what is a urachal anomaly? It's a embryologic structure that normally should close at birth. A very, wide spectrum of abnormalities, which I'm going to show you here in this diagram. Normal should be involutes. There is this, urachal remnant here, and this should just be fibrous. It should just close off. Urachal sinus would be, there's a little like outpouching there at the umbilicus, completely patent urachus, as in our case here. And then there's urachal cyst, where it's just in the middle and it closed off proximally and distally. And if it's just connected to the bladder, that's a urachal diverticulum. We did the, sometimes we did the ultrasound, and I think that was enough. And with the physical exam findings of the urine coming out of the umbilicus, I think that was enough to be sure the patent urachus. But in cases where they're a little bit unsure, the urologist may want us to do a VCUG and see if we see contrast actually going through that patent urachus to the umbilicus. And we've seen that on a couple occasions. Fistulogram would be going from the opposite direction and injecting contrast from the umbilicus and seeing if it connects to bladder. Ultrasound, which we use in this case, is going to be the least invasive. They are at risk for getting urachal adenocarcinoma, and it's a really important point to make, because whenever people think of the bladder or the ureters and the associated with malignancy, they think transitional cell carcinoma. So this is always one of my questions to residents. What kind of cancer do you think they'll get? Almost always they want to say TCC, and that sounds very logical given what happens in the bladder and the ureters. But this is an unusual kind of cancer, an unusual kind of place, so urachal adenocarcinoma is what they tend to get. Let's look at a 2-week-old female with bilious vomiting. This is contrast in the stomach, and it's very dilated. Additional images that we got on this exam showed malrotation, but no volvulus. Patient had a barium enema at a later time, diffuse microcolon. Notice the caliber of the rectum is larger than adjacent, more proximal colon. So it's not a case of Hirschsprung's disease or total colonic Hirschsprung's disease. Patient also had an ultrasound which showed this bladder to be really large and floppy and irregular in contour. There's some layering debris there as well. So this is a rare case, but in the setting of for a lecture in congenital GU anomalies, didn't feel that I could leave this out. It's called megacystis microcolon intestinal hypoperistalsis syndrome. I wish I had a simpler name, but there is someone who first described it, so Burdon syndrome might be a little bit easier to say and to remember. This happens more in females than males. It's a pretty severe form of obstruction in newborns, as you can imagine. Nothing's passed through this colon. 20% are going to be familial, probably autosomal recessive, 80% sporadic. And what is it due to? It's due to abnormal interstitial cells of Cajal in the bladder and in the intestinal myenteric plexus. There's smooth muscle abnormalities as well. There's a whole host of abnormalities with this disease. It has a very poor prognosis. We don't see this often, but when we do, these patients don't fare very well. You can imagine how can you do surgeries and treatments on anomalies that are so vital to life, your bowel, for instance, and bladder function, kidney function. Let's look at a 3-year-old male with post-void dribbling and frequent UTIs again. Patient got a VCUG. So this is that oblique view. We see a normal caliber ventral urethra, and we saw this very small, faint additional urethra here. So this is an example of urethral duplication, another congenital GU anomaly that isn't common. So usually the functioning urethra is that ventral urethra, which I'm showing you here, and the dorsal one is the accessory ones. There's many subtypes to this type of condition. Normally, we'll evaluate it if it's suspected, usually by the urologist with a VCUG, or you can do a retrograde urethrogram as well. Typically, this is treated with surgery to preserve the normal function of the ventral urethra and to excise or block off the accessory urethra. This is the case of an 8-year-old female with a recent UTI. So patient got a VCUG again, and contrast is filling the bladder. This patient did not have reflux, but we do have this incidental finding of a dilated posterior urethra. Pretty dramatic, actually. When I very first saw this as a fellow, I thought that was pretty dramatic and some kind of terrible pathology, but it's actually just a case of what we call spinning top urethra, and that's such an apt name for it too. This may be asymptomatic. Sometimes it's associated with the UTI, reflux, or even dysfunctional voiding. It could be associated with congenital bladder neck anomaly, maybe withholding behavior on the part of the patient. So the treatment for this is voiding retraining, because it happens in a lot of girls that want to, holding on to the urine and don't want to go. So sometimes it requires a little bit of retraining on when to go and maybe biofeedback training. But this is not really a pathologic condition unless the patient starts to have frequent UTIs or other difficulties. So here are my references here, and I just want to thank you all for giving me this opportunity to talk to you all today.
Thank you so much, Matt, for this wonderful session. Some really interesting cases, which you showed over there with fabulous imaging, like beautiful images.
Oh, thank you. Thank you very much.
I work in a cancer hospital, so this was like a great revision for me because I rarely end up seeing the benign spectrum nowadays. So it felt really nice to see all of them. For all the attendees, do put any questions you have in the Q&A, and I'm sure Matt will be happy to take them. We also see some urachal malignancies, Matt, but almost all of them in Tata are urachal RMS, rhabdomyosarcoma, because that's sort of the spectrum we get.
Oh, wow.
Supravesical soft tissue masses, and
Yep.
when they it was basically rising from the urachus. So I've seen at least two of them till now. Okay, so Ashok Chaudhary is asking a question: how to divide ureter into proximal, mid, and distal? Is there a landmark?
I'm sorry, can you repeat the question?
Yeah, Ashok is asking how to divide the ureter into proximal, mid, and distal. Is there a landmark beyond which you say this is proximal ureter, this is mid ureter, this is distal ureter?
Oh, that's a good question. I think typically I just divide the ureter into three parts. And so proximal is going to be, probably coming off at about the mid aorta for me. And the distal ureter is going to be closer to the iliac crest. I think that's typically where I divide it, but I don't actually use any technical landmarks.
Got it.
When we
Does it
do
matter to the surgeon? I mean, or to the referring physician? Do they ever call you and ask about the precise sort of section of the ureter?
No, I never got that question. When we do ultrasound, we take three sections. The proximal includes usually like the lower pole of the kidney and as much ureter as you can get in the image. And then the next one would be, wouldn't include the kidney and doesn't include any images of the bladder. And then the next section includes ureter where the bladder and where the ureter would be. So we kind of divide it into those three sections, and that seems to be good enough for the urologists. I suppose if they needed accurate anatomic localization of where the ureteral anomaly is, they will probably do a retrograde urethrogram in their own clinic. I've seen some of those images appear on our work list. And they're using fluoroscopy, so they have some bony landmarks that they can use.
Got it. Any more questions from the audience? Well, I think you really were very lucid, Matt. So not a lot of questions on the Q&A, but thank you so much for this wonderful session.
Absolutely, my pleasure.
Yes, and a pleasure for me as well to moderate this. Thank you so much to the team for giving me this opportunity. Oh, one more. Just okay. So this is. Oh, that's nice. So Asmarwati, I hope I'm pronouncing that correctly, is thanking you for the interesting topic and greetings from Indonesia. That's lovely to hear.
Oh, okay. Well, greetings from North Carolina. Thank you very much.
Thanks a lot.
Thank you. Thank you, Dr. Matthew. Thank you so much for, again,
Absolutely.
as Akshay said, such a wonderful illustrative lecture. Greatly appreciate your support to this program. And thank you, Dr. Akshay, for moderating this session. Thanks for making time and logging from India on your weekend and moderating these sessions. Greatly appreciate your help, too.
No, pleasure. Thankfully there was no India cricket match today. The T20 World Cup is happening in US, and I think the match was supposed to be in Florida yesterday, but got rained out. But yeah,
Correct.
so if it was today, then I might not have been able to do this. But thanks a lot, and you is doing great. I hope there are others who follow cricket as well, apart from the Indians.
It's pretty big in Southeast Asia, I guess. I mean, majority of our attendees are from there, I guess. But it's catching on in US too now. I know the US team has qualified for the T20 World Cup qualifier, so that's amazing.
Yeah, that's phenomenal.
Yeah.
Correct. All right. Thank you
Thank
so much.
you. Thank you. Thanks, Matthew. Thank you so much. So,
Absolutely. Yeah, absolutely. Thank you for inviting me.
Thank you. So let's move on to the next session. We have a small Q&A session right now. The quiz session. So we're gonna ask you a question and then give you 3 minutes to answer the question, and then we'll discuss the answer soon after that. Person who gets the right answer at the end of the month will get a surprise gift. So Can we have the quiz question on the screen, please, IT team? Thank you. Okay, so there you go. You have 3 minutes to answer this question, and the time starts now. This is a 16-year-old with pain abdomen. What is the diagnosis? You see a CT axial image at the level of the umbilicus, and then you see the contrast in there. I have an arrow to show the pathology. What is that? Is that an umbilical hernia? Option B is appendicitis. Option C is infected urachal cyst. Option D is diverticulitis. Please use the QR code. You can scan the QR code from your cell phone and you can answer the question. You have 4 options. This patient, 16-year-old, comes with pain abdomen. What is the diagnosis? A, umbilical hernia. B, appendicitis. C, infected urachal cyst. And D, diverticulitis. You have 2 more minutes. Again, what is the diagnosis on this axial CT image here with a 16-year-old with pain abdomen? Option A is umbilical hernia. Option B is appendicitis. Option C is infected urachal cyst. And option D is diverticulitis. Please scan the QR code. You have last 60 seconds. Make sure you scan the QR code and answer the questions. Please do not post any answers on the Q&A or the chat box. Make sure you scan the QR code and answer in the options you get when you scan the QR code. Now, last 30 seconds. Your last 10 seconds. All right, great. Can we go to the next slide, please? The answer for this question is infected urachal cyst. That's answer C. Yeah, if you see that image again, you see that axial CT section, you see at the level of the umbilicus, you see there is a fluid-filled enhancing a lesion there or possibly a collection there with few gas locules within that. So that's a typical location of a urachal cyst. And that's infected because of the fat stranding, peripheral enhancement, and gas locules within that. So answer is C, infected urachal cyst. Thank you so much. And we also have a QR code to assess this session to give us the feedback. Please make sure, can we get the QR code on the screen, please? Okay, there you go. So this is please use this QR code to evaluate this session, and this evaluation is required to issue certificate for those who complete. So kindly evaluate this session, use the QR code, and so that's it from today's session. So we had a great session in pediatric congenital GU abnormalities. And please log on 2 weeks from now, 7th of July, 2024. We'll have our next session on comprehensive review of rectal cancer imaging, which includes cross-section imaging, both CT and MR, and that would be by Dr. Neeraj Lalwani. He's a professor in Virginia Commonwealth University, and he's also editor-in-chief of Abdominal Radiology Journal. So please look forward for this session on 7th of July. Thank you so much.
Jackie, I
Yes.
have two announcements.
Please.
Yes, the first announcement is our lucky person for last month is from Myanmar. And the second thing is for residents, we will have the case conference next weekend on Sunday. So I will send out the flyer to your email for the trainings. So if you have time, please join. It will be cardiothoracic session. Dr. Michael from Duke will give us this conference. It'll be fun. Thank you.
Thank you. Thank you so much, Nat. Thank you. So thank you all so much for attending this session. Thank you so much for all the committees who work tirelessly behind the screens. Thank you, Dr. Akshay, moderator for this session, and Dr. Matthew Thompson for an excellent lecture for this session. Thank you all the panelists for joining us. And thank you so much for all the attendees who've been constantly supporting this program and attending this. Thank you so much.